Hi, I'm Martin Burns. I'm one of the 4 researchers who participated in this particular piece of work, and I'm delighted to be able to present this to you. I'm sorry I'm not doing it in person though. I was really looking forward to being in Abu Dhabi with everybody, but it's going to have to wait till next time. So, video it is. I do want to disclose a conflict of interest. I'm a minority holder in Bruin Biometrics, and although the research that we've done here, much of it is actually independent research, some of it was including one of our products, so I need to be able to make that extremely clear. I don't think it affects any of the analysis and particularly the conclusions, but I at least want to make sure that you're aware of it. What we did was we really tried to look at the clinical system or the protocols that are in place all over the world actually. We've got the EPUAP, MPIAP, PPPIA guidelines, which of course we're all intimately familiar with. And then at the country level, we've also got AHRQ in the United States, and in the United Kingdom, we have this guideline here, which is CG179, which deals specifically with the prevention and treatment of pressure injuries, pressure ulcers, within the England, NHS England setting. And the question we asked ourselves was, is prevention possible from a clinical perspective, given the care pathway as it's currently designed? We used a systemic root cause analysis and a systemic analysis, which has got feedback loops in it. So it's quite a familiar safety engineering approach to the way that care pathways are looked at, or indeed any system involving people in a disparate set of settings. One of the things that's been incredibly clear is that if you look at the current standard of care, and we're just going to focus here on the acute setting, that when patients are admitted, they're classified into being at risk or not at risk. Van der Vee tells us that about 41% of patients are at risk in the acute setting. And then Okonkwo in 2020 breaks that down further by actually using real-world clinical data by looking at the patients according to their risk. And those are patients who've developed pressure injuries, stage 1, according to their risk. And what you can see here on the right side of that pie chart is that in the grey and the moderately blue section, about half of the patients, about 49%, have developed a pressure injury in Okonkwo's study. And it's classified by risk. One would think, therefore, that if you look at the very high risk, that would be the area that would be developing most of the injuries, but actually they're not. So what we see here is that about half the patients who form the moderate risk or the mild risk area develop pressure injury stage 1, and actually they don't receive what is referred to as enhanced prevention. In other words, what you would familiarly know as increased offloading or mobilization. That matters because when you look at the way that CG179 actually works, from a clinical perspective, if you put it into a decision tree the way we've done here, I've not put in the transition probabilities because it becomes too complicated. Another talk deals with transition probabilities. But here, if you just look at it from a decision tree perspective, what you find is that you have patients stratified by risk. No risk, at risk, or high risk is the basic construct here. And during stay within that rectangle, you can see that the path that the patient goes down differs according to the type of risk. So high risk, for example, has rounding every 4 hours, versus at risk is rounding every 6 hours. Rounding is another word here we're using for offloading. I know that can be a bit confusing, but that's what that means. And then at the end of the patient's stay, they're either discharged, they die, or they have a confirmed category 1 through 4 pressure injury. And at that point, the way that CG179 is written is that actually the interventions at the anatomies are then applied. In other words, you have a confirmed injury by visual and skin inspection, and it's at that point that interventions occur at the particular anatomy. That's important because when you look at what's now known about etiology and this all the way goes back to at least the 1950s from Koziak, but actually has been added to very recently by work by Okonkwo and others, and also here in this diagram by Moore and her research partners, that actually we know that below the skin surface there's an awful lot of activity going on. There's a damage cascade, which is microscopic. It's not available to be seen by visual, and certainly not detected by tactile changes. ICD-10 in the US version refers to at least one of these processes as persistent focal edema. Then above the damage manifestation threshold is this macroscopic damage, and practitioners are used to assessing that using skin assessments, visual assessments, and those tactile assessments as well, and also looking for temperature changes. We also observed in our analysis that the way that the care pathways are actually written is that this idea about when you take intervention at a specific anatomy, not for the whole body, this universal intervention, but rather for a specific anatomy, waits until such time as a confirmed ulcer is manifest. That presents at least two major other results that come from this analysis, which tie in here. And what they are is that the subjectivity of skin and tissue assessment is quite wide. So when one looks at the sensitivity and specificity, the sensitivity, according to Pancorgo Hidalgo, is about 60%, and specificity is about 50%. In other words, an awful lot of patients get missed or are overtreated. The problem gets really much worse for dark skin tone patients. And again, we intuitively know these things. This is not necessarily new, but what we've done here in this analysis is to pick apart the care pathway in a structured way, and we can now see where the weaknesses are. So what does this lead to? Well, this is quite a dense set of results and conclusions, but I think it's worthwhile being pedantic and walking down through this. So if you'll indulge me, here's what we found. The issue of latency, and this is diagnostic latency, in other words, not being able to detect the incipient persistent focal edema, or other changes in skin and tissue in an objective way, it's just too late. And then we've got interventional latency, in other words, the shift from universal all-body interventions down to the anatomy-specific interventions is also too late. And what's clear from the analysis is actually this is systemically hardwired into the care pathway itself. The way the care pathways are written hardwires this behaviour in. The risk assessment scales have been debated for years, and for as long as I've been going to these conferences, and it's been at least 10 years now, every single conference has included a debate about risk assessment. I'd like to give you a slightly different lens from this analysis, please. And that lens is the following. Risk assessments address the question of, is my patient at risk for a pressure injury or pressure ulcer? And the answer is yes, no, and varying degrees of risk thereafter. What it doesn't do, though, is answer the question of where. Where on my patient is a pressure ulcer going to develop? Now, developers of risk assessment tools very proudly and quite rightly talk about the sensitivity and specificity of those tools, but the trouble with it is it's about the whole body. Now, if you were dealing with congestive heart failure where you've got one heart, the question of where is obvious. I'm at risk for a heart failure. Where? Well, at my heart. So I've got one place. Pressure injuries don't work that way, as you all know. So you have multiple places across the body where you could in fact develop them. And what risk assessment tools do not do is answer the question of where. And so you result in, at least the way that CG179 is written, in waiting. And the waiting persists until there is visible or tactile skin damage. And what's perverse about it a little bit more is that those patients in the Okonkwo study who are mild to moderate risk may not actually even receive the enhanced universal interventions until much, much later. And they're still developing pressure injuries at a rate that's equivalent to severely more at risk patients. There's another topic here, which is that care pathways as they're currently designed do not proximally diagnose incipient persistent focal edema. And we do know from the literature that abnormal persistent focal edema, sometimes it's referred to as just edema, or subepidermal moisture has been the term that, and this is the conflict where my company has been promoting, and other researchers like Bates Jensen and so on. But we do know that's a risk factor for later pressure injuries and pressure ulcers. The further piece of analysis shows that actually an over-reliance on skin and tissue assessments as the triggering point for anatomy-specific intervention occurs once the damage has been observed, and that really needs to be challenged. We know that in some of the latest research that prophylactic use of dressings, for example, in the operating room have gone some way to address this. It's prophylactic, but it's not certain about whether the patient is or is not compromised in their skin and tissue. So where we conclude is that for full prevention to occur, and it cannot under the current pathway as it's designed, but for full prevention to occur, the issues of diagnostic latency and anatomy-specific interventional latency simply have to be addressed. Thank you.